Hi guys, this is our review video for Pharm for asthma and COPD treatment. For this, we'll go over the mechanisms of the drugs, just like the lecture content, but I'd recommend using Sketchy for memorization, in addition to Anki. It helps a lot with understanding. So anyways, we have the drug summary right here, and these are just all the drugs we need to know for this particular lecture, and we have the chart right here for the different types of drugs. Our bronchodilators, our anti-inflammatory agents, typically will be a combination of those two in the treatment of asthma and COPD. So the first question is, what is asthma? So asthma is a chronic lung disease caused by inflammation and bronchoconstriction of the small airways. 1 out of every 12 adults has some form of asthma. Asthma itself is Greek for panting. Symptoms include cough, wheeze, shortness of breath, and chest tightness. Really, it's the conducting zone of the lungs that is the most impacted, not the respiratory zone, the bronchioles. Why would that be the case? Well, just think about bronchoconstriction, smooth muscle constriction. We have mucus here, so extra mucus, right? There's a lot of opportunities for things to go wrong in the conducting zone, specifically things related to inflammation and bronchoconstriction. All right, so what is the cellular mechanism behind asthma in an asthma episode or an attack? So we have the early phase, which is the first several minutes of an asthma episode. You have mast cell activation by exposure to allergens, and this will result in the release of bronchoconstrictor mediators to get the smooth muscle to contract. And so this is our histamine, our leukotriene, C4 and D4. We'll see B4 and E4 later, prostaglandin D2. And so basically the general mechanism is you have an allergen come into your conducting pathway of the respiratory tree. It binds to a dendritic cell. The dendritic cell presents that allergen to a T helper cell. The T helper cell is going to release signaling molecules, these interleukins, to plasma cells, which are going to release IgE antibodies. So this antibody right here, IgE, is super important for pro-inflammatory response, and it will be a target for one of our drugs overall. Those antibodies will activate our mast cells, and our mast cells release histamine, leukotriene, and prostaglandin, which will promote inflammation. Then we have going back to our T helper cells. They're going to signal eosinophils to also release cytokines and leukotrienes. And our friends, leukotrienes, in particular, are going to be associated with inflammation. Same with our cytokines. All right, so then, what are these inflammatory mediators? We're starting to see them already here. There's more than 100 different ones involved in asthma, but they include lipid mediators, cytokines, chemokines, and growth factors. Basically, what do these mediators actually do? They can cause contraction of the smooth airway muscle, cause hypersecretion of mucus, plasma exudation, which is the release of the plasma component of the blood into airways, and cause edema, extra retention of fluid in the airways, right? We're talking about the conducting zone. So microvasculature leakage, and then activation of sensory nerves, and giving us some pain. All right, so if you have chronic inflammation due to asthma, this can lead to remodeling of these airways, right, the bronchi. In particular, the remodeling that we see over the long term is hyperplasia, which means an increase in number. And so hyperplasia specifically of smooth muscle cells, so an increase in number of muscle cells, and then hypertrophy means an increase in size, so hypertrophy of smooth muscle cells. Why would this be the case? Well, they're being worked out. All right, increase in number of blood vessels, angiogenesis, is also a result of chronic inflammation, and part of what we consider remodeling, and then an increase in number of goblet cells, which we call goblet hyperplasia, aka increased mucus production. So here's just an example of what long-term remodeling would look like for a bronchi, and we can see here on the left-hand side, it's normal looking. On the right-hand side, we can see that the nasal membrane has increased in size. Fibrosis means just more connective tissue. And then we have smooth muscle hypertrophy, right? There's more of these guys than over here. Increased mucus production right here due to goblet cell hyperplasia. Increased number, hypertrophy again is increase in size. And then increased vascularity, angiogenesis. All right, so then how would you go about diagnosing asthma? Well, we've already seen this a little bit in our physio lecture, but in particular, first thing you do is you look at your clinical history and your symptoms, right? What are the symptoms? Cough, wheeze, shortness of breath, chest tightness. Then you can confirm with a spirograph, specifically forced exhale volume in 1 second, and then forced vital capacity is the total forced expired volume from one breath. And for obstructive diseases such as asthma and COPD, you would expect the ratio of the forced expiratory volume in 1 second over the forced vital capacity to be lower than 0.75. So you have a decrease in this ratio. Right, air gets trapped in the lungs with chronic asthma or asthma and COPD. All right, and then if you were to give your patient a bronchodilator and there's improvement, this is highly suggestive of asthma and not something like fibrosis, which is additional connective tissue. All right, what about acute exacerbation for asthma? How would you diagnose that? We have a mnemonic, A chest, and this isn't from the lecture, but this is just good to know. A stands for altered consciousness or arrhythmia. C is if they come in blue, right? Cyanosis, which is a result of an increase in partial pressure of carbon dioxide, so cyanosis means look blue. H is for hypotension, low blood pressure, and hypoxia, low O2 in blood. E is for exhaustion from fighting to breathe. S is for silent chest due to severe bronchoconstriction, and then T is for threatening peak flow, so they are producing less than 33% of their best flow. Breathing. All right, so that brings us to COPD, which stands for chronic pulmonary obstructive disease. What is it? It's a group of diseases that cause breathing-related problems. This includes emphysema, which is air-filled enlargement of body tissue. This is due to really destruction of lung parenchyma, which is just what that means, lung tissue. And so, you have destruction of elastic fibers around the alveoli, so they expand more and they can't contract as easily. And then you also have another So you have emphysema for COPD, and then you have chronic bronchitis are the two primary diseases in this group of diseases we call COPD. And so chronic bronchitis just means long-term inflation of the bronchioles, or the bronchi. All right, and so what are the causes? Typically, this is smoking. Generally, it's like 20 packs per year is enough to do it, but it's abnormal inflammatory response to particles or gases, typically from chronic cigarette usage. Okay, what symptoms do you have in COPD? Recurrent wheeze, recurrent respiratory infections, frequent cough, dyspnea, which is difficulty breathing, excess mucus, phlegm, and sputum. And I think it's funny that we have so many names for mucus, but phlegm and sputum are names for mucus made in the lungs only. And then another symptom of COPD can be weight loss. All right, typical presentations of COPD. We remember with blue bloaters and pink puffers, right? We said that COPD is a group of diseases, but our primary two are emphysema. You have destruction of lung tissue, results in like air-filled enlargement of the body tissue. You see people with like a barrel chest because air is trapped. And then you have chronic bronchitis. So blue bloaters are for chronic bronchitis, a productive cough, meaning mucousy cough, difficulty breathing, dyspnea, obesity, and then looking blue, cyanosis. And then pink puffers for emphysema, thin body, pursed lips for helping with breathing, such that their damaged lung tissue isn't going to collapse due to the dynamic changing result of air flowing through the lungs that we learned about in physiology. All right, so additional physical findings for both of these may include increased rate of breathing, barrel chest, which is due to both of these are obstructive pulmonary diseases, so trapped air, accessory muscle usage, and then coarse crackles as you have bronchioles and alveolar sacs maybe open and close as a result of air getting in and not. And then asteritis, I can't pronounce anything. This is like flapping, like muscle tremor, flapping hand, I think is the typical presentation. All right, so in terms of the pathophysiology, we said that primarily cigarette smoke or other irritants is what do this. That's going to activate epithelial cells and macrophages, right? Macrophages like to gobble up things. Epithelial cells will be activated as well. After these guys are activated, they're going to go ahead and release inflammatory mediators to attract other cells. In particular, leukotriene B4 is our primary one, and this is going to attract neutrophils. It's a chemotaxant, which means it attracts cells. Then we have monocytes, T lymphocytes will be attracted. Macrophages then will release proteases. Neutrophils will also release proteases, and proteases will result in alveolar wall destruction, which we see in emphysema, and mucus hypersecretion. All right, and then our T lymphocytes can also contribute to alveolar wall destruction. We know that T lymphocytes can go around and result in cell death. All right, so our epithelial cells will release fibrogenic factors. In particular, fibrogenic factors will be taken up by our fibroblasts, and they will result in excess connective tissue being made. And that is the definition of fibrosis, which is you have too much connective tissue, and as a result, it's hard for our vessels to be able to expand. All right, so a little bit more on the pathophysiology over here. So loss of lactic recoil, we see in emphysema a lot, and then airway narrowing as a result of inflammation. We said that our neutrophils and our macrophages release proteases, and our basically excess protease activity, which we looked at over here, is going to lead to destruction of lung tissue, the loss of alveolar support and elastic recoil. This leads to the enlargement of the alveolar sacs, which is kind of the definition of emphysema. And then you have, with excess protease activity, you also have the tendency for smaller bronchioles to collapse, causing for airway to be trapped. You also have, as part of the inflammatory response, an increase in oxygen-free radicals. This will result in a couple of different things, one of them being mucosal edema, which is extra fluid in our mucosal layer, hypersecretion of mucus from our goblet cells, bronchoconstriction, and then fibrosis, extra connective tissue, and the net result is that as a result of an increase in oxygen-free radicals, in irreversible airway narrowing. All right, and so the overall summary of this is that you have, it's difficult for air to get in and out, air gets trapped, extra mucus is going to be hard to get rid of, and then this can be kind of a cyclic thing in terms of this will call this can cause recurrent infections, which can perpetuate the inflammation that is really the hallmarker of COPD. All right, diagnosis, we're almost done. We have basically the same thing as for asthma, right? Asthma is an obstructive pulmonary disease. COPD is chronic obstructive pulmonary disease, and we're looking for the ratio of forced expiratory volume in 1 second over the forced vital capacity, the total amount that you breathe out, to be less than 0.7, that ratio. You can also do a couple of different things, pulse oximetry, and then do some blood work to look at the O2 content in the blood, and then get blood count. Chest x-ray can help. You generally see increased intercostal spaces and a flattened diaphragm, and then you can do genetic screening, and then this is just a reminder here that COPD and asthma are obstructive pulmonary diseases, and you see a decrease in our dynamic lung volumes. All right. Okay, so how do we actually go about treating this stuff? So we have different drug delivery methods. We have basically inhalation, we have oral swallowing stuff, and then you have injections, which are para-enteral, which means outside the intestines, aka injection to, say, the muscle. There's pros and cons in all of them. For inhalation, you have rapid onset of effects, right? This is why we typically use our short-acting beta agonists with our inhalers. And then you have, for the oral method of taking in, swallowing, you need a larger dose for the same effects, and you have more side effects. And then injections, aka para-enteral, is outside the intestines. It's going to have a higher plasma concentration, and then you have even more side effects. So this is kind of last resort for treatment of asthma and COPD. Use it on severely ill patients only who can't absorb the medication otherwise. All right, so just a quick comparison of COPD versus asthma. Cells involved in COPD typically are neutrophil and are macrophages, or endothelial cells as well. They have an increase in T lymphocytes, but really promoting inflammatory response a whole lot. And then our mediators, important ones, leukotriene B4. This is just saying, hey, neutrophils, you should show up. And they're released by our macrophages and endothelial cells. And then interleukin 8, IL-8, is going to attract granulocytes. And then our necrosis factor alpha promotes inflammation and causes necrosis and apoptosis. So the consequence of COPD, you can have squamous metaplasia of epithelium, right? Go from respiratory to squamous, simple squamous epithelium. Parenchymal destruction just means tissue destruction. Mucus metaplasia, aka lots of mucus, and then glandular enlargement. In comparison, asthma, we have a lot of eosinophils, small increase in macrophages, increase in T lymphocytes, and activation of our mast cells. So a lot of inflammation and bronchoconstriction. We also have leukotriene, which in this case is leukotriene D4. B4 is our chemotaxin D4. And then we'll learn about, we have C4 and E4 are going to just promote inflammation. And then our interleukin 4 and interleukin 5, and there's many others. These guys are going to do a lot of attraction of or recruitment of different cells to promote inflammation. All right, and then we also have fragile epithelium, thickening of the basement membrane in asthma, mucus metaplasia, aka more mucus, and glandular enlargement. All right, so what drugs do we use in asthma and COPD? We take really a two-pronged approach. We have our bronchodilators to remove bronchoconstriction, and then anti-inflammatory agents. And with our bronchodilators, we'll see we have our beta-2 agonists, which are dealing with the sympathetic nervous system. Then we have our muscarinic antagonists, which is our parasympathetic nervous system. We have our methylxanthines, which is going to have to do with cyclic AMP and helping with bronchodilation by increasing the concentration of that or maintaining the concentration of that. Then we have our anti-inflammatory agents, our corticosteroids, right? These guys are first response, fast-acting, semi-fast-acting, but for long-term treatment. These guys are, right, we know steroids will go directly into the cell, so this is kind of a slower-acting response, but you can have inhaled or swallowed versions of corticosteroids, and that's about regulating expression of inflammatory mediators from the production of them, right? Transcription, translation. Leukotriene modifiers, right? Leukotrienes are pro-inflammatory mediators. So can we keep these guys from doing what they're supposed to do by blocking them from being received or blocking them from being made? And then degranulation inhibitors, can we attack our mast cells and keep them from releasing their pro-inflammatory agents, such as histamine? And then antibodies, can we just target, for instance, IgE, which is an antibody? Can we use another antibody to target an antibody which promotes inflammation and therefore reduces inflammation? All right, so we'll take a quick pause there and we'll look at the mechanism of action of each of the drugs. All right, so now we're going to look at our bronchodilators, specifically our beta-2 agonists is where we're going to start. Really we're focused on dealing with the smooth muscle, and so we'll talk about the mechanism of action, but just to visualize this a little bit, we have the smooth muscle wrapping around our bronchi down to our bronchioles, and so we think about our innervation of the lungs. Remember we talked about the diaphragm contracting, and then from the phrenic nerve, and then we didn't really talk about in physio the smooth muscle inside the lungs itself, because that's not really causing the inhalation, right? When we're talking about the diaphragm moving and the intercostals moving for inhalation and exhalation, and your abs moving. We have the intercostal nerves and the phrenic nerve, but we also have the sympathetic nervous system dealing with the smooth muscle in the lungs themselves. And so, in terms of what's going on, we have our sympathetic nervous system can cause bronchodilation, right? Because sympathetic nervous system is fight or flight. You want to be able to breathe if you need to, either of those two things. And so really we're looking at a mechanism that has to do with G-coupled receptor, right? We're familiar with this for catecholamines. So for B2 receptors, that's a GPCR with GS as the G protein. And this is primarily epinephrine that would affect the B2 receptors. And so agonists that do the same thing as epinephrine will activate this pathway. And so basically what happens is you have our agonist come in, binds to a receptor, the alpha subunit of GS disassociates, it will bind to adenyl cyclase, which is going to convert ATP to CAMP. CAMP will therefore be increased in concentration. This is going to activate protein kinase A. Protein kinase A goes around and phosphorylates things, but specifically, it's going to phosphorylate another G-coupled protein receptor, GQ. And normally what GQ does, normally GQ will stimulate phospholipase C, PLC, which is going to break down this membrane phospholipid PIP2 into IP3 and DAG. All right, and so the result of this pathway is that you're going to phosphorylate GPCR, you're inactivating GPCR, which means that you're decreasing IP3. Okay, and so then you go to the sarcoplasmic reticulum. Now you have less IP3, and the sarcoplasmic reticulum has receptors for IP3, and we know inside of the sarcoplasmic reticulum you have calcium, and so these receptors for IP3 are going to, when IP3 binds, allow calcium to leave the sarcoplasmic reticulum, and so if you are phosphorylating GPCR, you have less IP3, therefore less binding to these IP3 receptors, therefore less calcium in the cytoplasm of the smooth muscle cells around the bronchi and bronchioles, and therefore less ability for the muscle to contract because you have less calcium, and therefore less and you'll have bronchodilation as a result. And so remember, just like why does calcium matter so much? We'll go to our sarcomere model. We know that when calcium comes out of the sarcoplasmic reticulum, it's going to bind to the thin filament. In particular, it binds to our troponin, which will cause our troponin to move, which exposes our actin heads to our thick filament, which allows us to go through the contraction cycle. All right. So that's the mechanism of action for the beta-2 agonists. And the question is, what's our clinical usage for these drugs? And then what are they? What are the actual drugs? So clinical usage, they're first-line drugs for asthma and COPD. Why? Because they generally act pretty fast. There's three classes: short-action beta-2 agonists, which we call SABA. Then we have long-acting beta-2 agonists, LABA, and then ultra-long-acting beta-2 agonists, ultra-LABA. SABAs are the true first-line treatment for acute asthma symptoms. They're commonly used in conjunction with the long-acting beta agonists, LABAs, inhaled corticosteroids, and then long-acting muscarinic antagonists when treating COPD. Our long-acting beta agonists are the second-line treatment in asthma. They're used with generally when inhaled corticosteroids and SABAs are not helping. So what are they? Well, the nice thing is they generally end in aryl, and so we have our SABAs, albuterol, levobuterol, metaproterenol, pyrbuterol, terbutylene is our exception, and then for our LABAs we have salmeterol, formoterol, and indacaterol. For both of these, we have mnemonics in sketchy, which I would again suggest using. It makes it a lot easier. But I just thought when I was writing this out, Errol is the owl from Harry Potter. He's often confused. Maybe he's struggling so much because he has asthma, and Errol could use some albuterol or perhaps Pharmacology. All right, so those are our beta-2 agonists, which is our first type of our bronchodilators. Then we dealt with the sympathetic nervous system. Now we're dealing with the parasympathetic nervous system, so our muscarinic antagonists. And so you think to yourself, what would the parasympathetic nervous system do in the case of breathing, right? We have parasympathetic is rest and digest, and so they're not fight or flight. Fight or flight is you need to breathe more, so parasympathetic causes bronchoconstriction, and so we're going to deal with antagonists to the parasympathetic receptors. In particular, we have the M3 receptor, which is also a G protein-coupled receptor. And these muscarinic antagonists are going to inhibit this pathway. But what is this pathway that they're dealing with? Well, we mentioned that the beta agonist pathway is going to result in more protein kinase A, and that does phosphorylation. In particular, it phosphorylates GPCRQ, and that results in less IP3. And so this IP3, which deals with the sarcoplasmic reticulum calcium channel, is really what's going on here. We have our GQ protein associated with the M3 receptor. It's the same GQ receptor that gets phosphorylated after GS gets stimulated with our beta-2 agonists, right? And so the idea here is that the alpha subunit will dissociate. It will go to bind to phospholipase C, which will break down PIP2 into IP3 and DAG, and IP3 will bind to the IP3 receptor, release calcium, lead to muscle contraction. All right, so that's if this pathway is being activated. Our antagonists are going to inhibit this, and therefore result in this whole pathway being inhibited, less calcium being released into cytoplasm, and therefore less smooth muscle contraction, and therefore bronchodilation. All right, so what are the clinical usages? Our muscarinic antagonists are generally not as effective as beta-2 agonists for asthma, but they can be paired with beta-2 agonists, so you kind of step up your treatment. In COPD, generally these drugs, chronic obstructive pulmonary disease, they can be as effective or even better than beta-2 agonists in COPD versus asthma. We said generally not as effective as beta-2 agonists, but in COPD they can be better, and they cause a decrease in the vagal tone, the constant vagus nerve stimulation that reduces and as a result reduces bronchoconstriction, which is what we see here with the vagus nerve coming down to our M3 receptors, and if you add our antagonists, you're just going to have less constriction, which is exactly what we were saying up here. All right, and then third usage is to reduce air trapping and improve exercise tolerance in patients with COPD. So COPD is kind of the disease of choice for this particular drug. Just like our beta agonists, we have short-acting and long-acting. Short-acting we would call SAMA for short-acting muscarinic antagonists, and the long-acting is LAMA. LAMAs are used as additional bronchodilator in asthma patients, not on long-acting beta agonist LABAs. All right, so what are the actual drugs? We have our SAMAs and our LAMAs, and then using LAMAs and LABAs in combination, we have SAMA, we have ipratropium bromide, and this is often used in sort of rescue cases, right? It's just a little bit faster acting. Then we have LAMA. These are used generally when the LABAs are not enough, the beta agonists are not enough. So we have tiopropium bromide, glycopyrrolate bromide, and umeclidine bromide. I can't pronounce anything. Then we have our combinations here. Glycopyrrolate is used often in combination with the LABA indacaterol, and then umeclidine used in combination with the LABA vilanterol, and then tiotropium used in combination with oldaterol. All right, and so this is often used, the combination is often used in treatment of COPD. All right, that brings us to our third type of bronchodilator. The good thing is we just have one drug, our thiopylene. Again, suggestion to use sketchy because there's a lot on this. Thiopylene is a methyl xanthine, which are purine-derived drugs, and so these are our purines, just as a reminder. Causes bronchodilation, has three mechanisms of action. The first is a phosphodiesterase inhibitor, and so as a reminder, we talked about phosphodiesterase when we talked about nitric oxide, and phosphodiesterase breaks down the CAMP that nitric oxide induced in smooth muscles, if you remember from the previous unit. And so CAMP, less CAMP will result in less calcium ion concentration, and therefore less muscle contraction, and therefore bronchodilation. All right, so if you have a phosphodiesterase inhibitor, you're going to maintain the CAMP's effect of bronchodilation by maintaining CAMP. All right, so we want to maintain CAMP because CAMP, this is a little confusing. CAMP is maintaining calcium ion concentration. CAMP is decreasing calcium ion concentration. And how is it doing that? We have our phosphodiesterase will break CAMP down, but generally CAMP activates protein kinase A, which increases phosphorylation of the GPCRQ receptor, which would normally, when activated, result in increased IP3. And IP3, CAMP will result in phosphorylation of this, resulting in less IP3, resulting in less release of calcium from the sarcoplasmic reticulum, therefore less calcium, less ability for muscle to contract, therefore bronchodilation. All right, so inhibiting the breakdown of CAMP maintains less calcium. So CAMP causes less calcium. So that was fine. All right, the second mechanism is antagonizing adenosine receptors. Don't need to know too much about this other than the net result is bronchodilation. Adenosine receptor activation leads to bronchoconstriction by stimulating the release of histamine and leukotrienes, which we know stimulate inflammation. All right, and our third mechanism is thiopylene is going to increase the concentration of interleukin-10, which releases anti-inflammatory mediators, and as a result, we have bronchodilation. All right, so theophylline is going to help in the management of persistent asthma. It's relatively inexpensive and is going to typically be used as an add-on, especially in COPD, but generally antimuscarinics, our LAMAs and our SAMAs, and then our beta-2 agonists, our SABAs and our LABAs are preferred. All right, so we'll take a quick pause there. Next, we're going to go into our anti-inflammatory agents. All right, so now we're going to go over our anti-inflammatory agents, specifically starting with our corticosteroids. And the basic idea is our corticosteroids, being steroids, can go through the plasma membrane of a cell, and then it's going to activate and or suppress genes. So enter the cytoplasm, bind to a receptor in the cytoplasm, move into the nucleus, and then regulate the transcription of our inflammatory mediators. So in particular, generally they upregulate lipocortin, also called annexin A1, which inhibits phospholipase A2, which normally converts phospholipids into arachidonic acids, abbreviated as AA, which can be converted into leukotrienes and prostaglandins. And leukotrienes and prostaglandins are our classic pro-inflammatory models, mediators along with histamine. All right, so this diagram is describing what we just said with the steps, but we have our corticosteroid comes in, binds to its receptor in the cytoplasm, then it goes into the nucleus where it can regulate transcription. In particular, it is dealing with the histone acetyltransferase, HAT, which does acetylation, and it can stimulate or inhibit that. And we know that acetylation increases transcription by unwinding DNA from our histones, right? Or unwinding the packing around the histones. All right, and then typically inflammatory stimuli, we're just given this with no explanation, so what the heck. But this is just a general pathway, and I don't think we need to know this specifically, but inflammatory stimuli, sort of a common inflammatory pathway. You have IKKB, which is a kinase enzyme responsible for inflammatory response. That's going to activate this transcription factor group, which includes P65 and P50, which are transcription factor subunits. And this group consists of NFKB, I think is the overall name. And then that will go into the cytoplasm and bind to regulatory regions on the gene to recruit or start transcription. All right, so then what are the clinical uses of our corticosteroids? Well, we have inhaled corticosteroids. They're the first line of therapy for persistent asthma. And so, right, you think about this entire pathway. Does this seem like a fast pathway to you? No. So it's going to take on the course of, it's a little bit longer than our beta-2 agonists. So our first line of therapy often uses like a daily puff. Often less effective for COPD, used in severe cases only. Intravenous IV steroids are used for acute asthma if lung function is less than 30%, and beta agonists are not helping. Hydrocortisone is a steroid of choice if you're using IV intravenous steroids. Prednisone and prednisolone are the most common oral steroids taken through the mouth, used for acute COPD exacerbation, but has relatively small effect. What are the effects of these corticosteroids on individual cells? Well, for our eosinophil, it's going to reduce the number of eosinophil by promoting apoptosis. Our T lymphocytes, it decreases the cytokines they release. Our mast cells, it's going to decrease the number. Macrophages decrease the cytokines they release, and then dendritic cells, which we know are often the first part of the inflammatory response for basically grabbing onto like particles that come into the lung. It's going to decrease the number of dendritic cells. Then on epithelial cells, it will decrease the cytokines and mediators they release. On the endothelial cells, it will decrease leakage, help decrease leakage. And then smooth muscle cells increase beta-2 receptors, which will help with bronchodilation and decrease cytokines against the expression of all these things. And then for mucus glands, decrease mucus secretion. So what are the drugs? Typically they end in "-one", but we have some IDES. We have the inhaled corticosteroids, beclomethasone, fluticasone, budesonide, glycisidine, and then flunitazolide. And then our systemic, so through IV or oral, hydrocortisone, prednisolone, and then methylprednisolone. Okay, so those are our corticosteroids. Then we have our anti-leukotrienes, and we know that leukotrienes are pro-inflammatory molecules. So basically, can we keep these molecules from getting to their receptors, or can we keep them from being made in the first place? So those are our two general approaches. And so the first one, basically keep our leukotrienes from getting to where they need to go to cause the inflammatory response, are our leukotriene receptor antagonists, and they bind to leukotriene LTD4 and LTE4 receptors to block activation. All right, and so basically, what that's saying is that right here, they're going to block our leukotrienes, right? We have B4, LTB4, C4, D4, and E4. And those are we just block the receptors, and as a result, you have a decrease in plasma exudation, so release less plasma from the blood going into the respiratory system. Then you have a decrease in mucus secretion, decrease in bronchoconstriction, and then a decrease in eosinophil recruitment. All right, so then we have our inhibitors of the creation of these leukotrienes. And so basically we have arachidonic acid, abbreviated as AA arachidonic acid can be converted into our leukotrienes by 5' lipooxygenase. All right, and so our next set of inhibitors, this is also abbreviated as LOX often, our next set of inhibitors will inhibit this enzyme and basically keep this conversion from our arachidonic acid into our leukotrienes from occurring. All right, and so that's our LOX inhibitors. And the LOX inhibitor is just going to block the formation of LTB4, C4, D4, and E4. BCDE. All right. Clinical usage of our leukotriene receptor antagonists. It's used for asthma management. It's not generally not used as a rescue treatment. Right? Rescue treatment, we're talking typically about our SABAs, short-acting beta agonists. Less effective than inhaled corticosteroids, okay, and less effective than our long-acting beta-2 agonists. But again, different pathway, different potential target, and so drugs can be used in combination. So what are our drugs? We have xylutrin, and then that's our LOX inhibitor. And again, sketchy is a good mnemonic for this. Then we have our leukotriene receptor antagonists, and these are our casts. We have Mont-E-Leucas, Zafir-Leucas, and Pran-Leucas. And Pran-Leucas is not used in the United States. All right, and then we have our monoclonal antibody drugs. And so the idea is twofold. We have pro-inflammatory antibody IgE. All right, and so IgE, an antibody itself, we have a monoclonal antibody which will bind to this antibody to block IgE's binding to receptors. Okay, and so that's the first mechanism, a antibody that binds to IgE, aka another antibody, to keep IgE from doing pro-inflammation, which is what it does. All right, and so this drug, we just have one, is omalizumab, and it blocks IgE from binding to the receptors on mast cells and therefore prevent their activation by allergens. And then it will also bind to B and T lymphocytes, macrophages, and eosinophils to inhibit inflammation. So it's blocking the binding of IgE to mast cells and our macrophages, eosinophils, lymphocytes. All right, it will also, by binding to IgE, right, one antibody binding to another, will basically help reduce the circulating levels of IgE overall. Right, they can then be picked up by, swallowed and destroyed by phagocytic cells. All right, without binding to the surface and activating a pathway. Okay, so then we have our, basically, IgE will bind to these different cell types, and then our anti-IgE antibody, aka omalizumab, is going to block the binding of this guy to all of these guys. All right, and then this is just saying our B lymphocytes often release our IgE antibody. All right, our IgE, we do not like him. All right, clinical usage of omalizumab is for a severe allergic reaction, reduces the requirement of having to use oral corticosteroids taken by mouth and inhaled corticosteroids, and as a result, it can reduce asthma exacerbations. However, it's at a very high cost, so I read it was $10,000 to $60,000 per year, so it's used infrequently. All right, then we have another antibody, or an interleukin, and so we have an antibody that's going to bind to interleukin 5, and so basically the idea is that interleukin 5, you can bind to the receptor for interleukin 5, or you can bind to interleukin 5 itself, and as a result, you're going to inhibit eosinophilic inflammation in asthma patients. And so interleukin 5 will promote our eosinophil inflammation, and so we have the antibodies that will bind to IL-5, and that's mepolizumab and rezumab, and then you have the antibodies that bind to the receptor for this guy on the eosinophils, and that's benrazumab. I can't pronounce anything. All right, so what are the clinical uses of these monoclonal antibodies? They're used to reduce exacerbations by 50% in severe asthma patients. They reduce the maintenance dose of oral corticosteroids by at least 50%, permitting many steroid-dependent asthmatics to come off steroid treatments completely. And then these antibody treatments have not been effective in reducing exacerbations in COPD, even though there's an increase in blood eosinophils. All right, so that brings us to our very last one, which is we're going to be targeting the release of pro-inflammatory mediators. So we have our mast cells, and our mast cells we know have granules of histamine. They're also going to have leukotrienes, and so we can inhibit the release of these with a drug called cromolyn. And again, sketchy is a good mnemonic for this. Basically, mechanism of action is that you are going to have basically block the release of our degranulation, or block the release of the granules from our mast cells, which we can see here had been activated by an antigen, aka duster pollen, coming in. Overall. So clinical use, no bronchodilator action, but can prevent bronchoconstriction. It's very insoluble. Large doses result in minimal systematic blood levels, only local effects. And then cromolyn sodium is used for prophylaxis of mid to moderate bronchial asthma. So treating yourself before you're experiencing symptoms, prophylaxis. All right, so preempting prophylaxis, or preempting, aka prophylaxis. All right, so this is just an asthma treatment chart. Basically, what are the preferred mechanisms, what are preferred controllers, what are the preferred drugs to give at each stages of asthma? So for symptoms that have been around for less than 2 months, use step 1, which is a low dose of inhaled corticosteroids, which is formoterol. And then other controller options, a low dose of inhaled corticosteroids whenever a short-acting beta agonist is taken. And then if the symptoms are twice a month or more, but less than daily, so symptoms less than twice a month, symptoms twice a month or more, but less than daily, step 2, daily low dose of inhaled corticosteroids, or as needed, low dose of the inhaled corticosteroid formoterol. Other options we can see here. Step 3 is symptoms most days or waking with asthma once a week or more. So a low-dose combination of inhaled corticosteroid with a long-acting beta agonist. And then the next step is symptoms most days or waking with asthma once a week or more, low lung function, a medium dose of inhaled corticosteroid with a long-acting beta agonist. And then the final step is high-dose inhaled corticosteroid and long-acting beta agonist. All right, so increase in severity symptoms as you go from step 1 to step 2. All right, important to know, leukotriene receptor antagonists remember, leukotrienes are pro-inflammatory mediators. Those are abbreviated as LTRA. All right, and then for COPD, we have different classes based on something called the CAT score. And so for class 1, which is the lower symptoms, a CAT score less than 10, it's recommended you give short-acting beta agonist and or short-acting muscarinic antagonists. The alternatives are SABAs with ASAMA, long-acting muscarinic antagonists, or a long-acting beta agonist. For class 2, CAT score greater than 10, long-acting muscarinic antagonist or long-acting beta agonist, and then the alternative is a combination of these two for COPD class 2. And then class 3, high risk of exacerbations, greater than 2 and or hospitalized in the last year, recommended LAMA, long-acting muscarinic antagonist, or a long-acting beta agonist with an inhaled corticosteroid. All right, alternatives, LABA with a LAMA with an inhaled corticosteroid, LABA and inhaled corticosteroid, theophylline, or a phosphodiesterase inhibitor. All right, so that's it. That was a lot. good job. I think this is longer than the lecture itself, but I tried to be a little bit more thorough. So hopefully that was helpful. It was helpful for me. Here's our drug summary. So this is a good place to come to memorize. And then looking at our sketchy video uploaded, or sketchy video, which you can hopefully find, which is very helpful. All right, bye guys.